All right, so this is about where we left off last time. Some of this is kind of a built-in review, so that'll work out well, I think. So we talked mostly about the glial cells last time. Remember that glial cells are ones that help neurons. So that's their job, is to help the neurons in some way. Mostly I talked about astrocytes and their function maintaining the extracellular environment around the neurons. And then we talked about like ependymal cells that will beat the cerebrospinal fluid, oligodendrocytes, etc. So this time we're getting on to the real stars of the show, the neurons. So again, we mentioned some of this last time, but in terms of the components of a neuron, there's 4 basic components. So we'll start where the slide starts. The first is the cell body. So what you've got here is kind of this generic picture of a neuron, not exactly. And in fact, afferent neurons, a lot of them actually have their cell body kind of away from the rest of the neuron. So this one is what we would associate with a motor neuron. So an efferent neuron is what's pictured for you there. Most of them are generally shaped the way that this one is. And so this is kind of my generic neuron here. So for this one, the body is this main part of it where the nucleus is. So the nucleus is there. Our machinery to make proteins is there. And that's going to be important because making proteins is going to be part of the repair process and the maintenance process. So we have to transport those proteins away from the cell body to get them where they need to go in order to repair the axon, to repair the terminals, etc. So main part of the cell, then the cell body. Then we've got the dendrites. So what the dendrites are, those are kind of the incoming signals. Those are the projections where we gather the incoming signal. So on this generic neuron, all of these then are the dendrites. So the dendrites communicate with other neurons, and they receive excitatory or inhibitory signals from other neurons. So they bring in signals or bring in information, if you will, from other neurons. Then we got the axon. So the axon goes away from the cell body, and it is oftentimes a long projection that relays the electrical signal away from the cell body out to whatever other cells that this neuron interacts with. So this is a motor neuron, then it's going to relay that electrical signal to muscle cells. Or if it's just a neuron in the central nervous system, it'll relay a signal to other neurons. So the axon then relays the signal away from the body toward the end of the axon, which is called the terminals. So that's the 4th part of a neuron. So the 4 basic parts of a neuron then, you've got the dendrites, bring the signal in, the cell body, which is where we make proteins, we repair the cell, and then we got the axon to conduct the electrical signal away from the body, and then the axon terminals, which interact with other neurons or muscle cells or other things. Other things I got on there. So the axon, remember myelination means effectively isolation of an axon. So what that does helps keep the electrical signal from degrading. It keeps the electrical signal strong, and that enables the electrical signal to move down the axon faster. And so I mentioned this last time, a myelinated axon is able to of myelination, so PNS is the peripheral nervous system. So what is the cell that's responsible for myelination in the peripheral nervous system? Anybody last time? It's called a Schwann cell, SCHWANN. A Schwann cell is myelinating in the peripheral nervous system. The example I always used to use is probably from a movie that none of you have seen, but there's an old movie called Billy Madison, and at some point in the movie, and so for whatever reason, I remember this. So cells are cells that myelinate the axon in the peripheral nervous system. And so what you got here, these are your little Schwann cells. So an individual cell wraps here. This is another Schwann cell here. This is another Schwann cell here, which is what we see in the central nervous system. Anybody remember this? Myelinates axons in the central nervous system. Okay. Oligodendrocytes. So it's a different cell type that myelinates axons in the central nervous system. Again, those are oligodendrocytes. And one of the important functional differences is whereas in the peripheral nervous system, the Schwann cells, you have a bunch of them next to each other that run down the axon. An oligodendrocyte can wrap around 60 different axons. One cell can insulate, one oligodendrocyte can insulate a lot of axons and neurons in the central nervous system. Talked about unmyelinated axons severance. So if you sever an axon, it means you cut it. And so we see that sometimes with injury. So one of the things to understand is if the axon gets cut, now the terminals down here don't have any signals from the rest of the cell. And in addition to that, remember that we only make proteins for repair and maintenance in the cell body. And so if we sever the axon and cut it, oftentimes we're not able to repair those axons. Sometimes we are. The more peripheral the damage, the more likely it is that we'll be able to repair that axon. But if we sever that axon, if we sever the connection to the cell body, then all of the cells that this is connected to get less input. And if we're talking about muscle cells, oftentimes those muscle cells will atrophy and sometimes they'll die. So if this is a motor neuron and we cut that axon, those muscle cells will often die as a result of losing innervation, losing connection to the central nervous system. Yep?
So a lot of times, like when they say you have nerve that can be broken bones and stuff, is that what happens? Like that?
Yep. Yeah. On some level, yeah, the axons get crushed or severed or something happened to them so they can't conduct their signal. And so then everything distal to that farther down the chain degrades and doesn't function anymore. Yeah. I was going to say something else, and I forgot. That's okay. All right, so in terms of white matter and gray matter, so this is going to come up when we talk about the central nervous system primarily. So if you look at cross-sections of the central nervous system, so that includes, again, the brain and the spinal cord. Oh, there's my little Schwann cell. And then there's an oligodendrocyte wrapping around a bunch of different axons. So what you're looking at here is a cross-section of the spinal cord. Down, so back to the brain. We send information back to the brain, up the cord, and motor information down the cord, away from the brain. So the transverse or horizontal cut or cross-section of the spinal cord. And so one of the things you've noticed here is that on the inside, or the deepest portion of the cord, it is a different color. So it's kind of this H sort of a shape of, in this case, it's tan-colored. But that is matter, as opposed to the more superficial parts of the cord are all white matter. So what is the difference? Why is there a different color for the more superficial parts of the cord? Why is there an H in the middle of the cord that's kind of a gray color? And the answer to that question is there are different things in each section of the cord. So superficial area in what is referred to as the white matter, these are all tracts of axons. TRACT, tract of axons. And so what that means is you've just got a bundle of axons. And remember that your axons, for the most part, are myelinated. So they're in a fat wrapping. And so that outer portion of the cord, or the more superficial portion of the cord, has a lot higher fat content because it's all those myelinated axons. And so that's what gives it that white appearance. As opposed to that H shape in the middle, that is gray matter, which is primarily cell bodies. Remember, cell bodies are not myelinated. And so because of that, they have more of that dark grayish color. So there's a lower fat content. So that's what gives it that more grayish appearance. The same thing when we talk about the brain. When we talk about the cerebral hemispheres, the outer portion of the hemispheres is called the cerebral cortex. It is gray matter. And then inside, deeper in the brain, you've got white matter because it's primarily tracts that are relaying information between parts of the hemispheres and then also the cord in some cases. So white matter, bundles of axons or tracts of axons, and it has a higher fat content. That's why it's colored that way. Gray matter, primarily cell bodies. So for example, because this will come up here in a second anyway, we talked about, thinking way back to the muscle chapter, remember we talked about alpha motor neurons. The motor unit was one alpha motor neuron and all of the muscle cells that it innervated. So the motor neurons then, the cell bodies of them, actually sit here in this anterior horn of the spinal cord. And so we send motor information out the front side of the cord, and we'll get to this more when we talk about the brain as well, or the central nervous system. So motor information goes out the front of the cord, and then sensory information comes in the back. So that's the way those two work. So all your alpha motor neurons then live in that anterior or in those ventral horns of the spinal cord, in that gray matter. All right, so my case study, it's a historical case study, obviously. So we're going to pretend that you're a physician in the US in the 1940s. A 4-year-old girl is brought to your clinic. I'm going to make sure I get all of her symptoms right. So she has had a persistent fever for several days, along with headaches, fatigue, vomiting, neck and back pain, as well as stiffness in her legs. On examination, you note that she has severe weakness in both legs, but the right side appears floppy and has no reflexes. So symptoms common to a lot of different infections. So between the distinguishing features are significant weakness in the legs, and particularly on the right side, a lack of reflexes. So what could be going on here, especially given the historical time period? Any guesses as to what our little 4-year-old might have going on? Carissa, what do you think? Make a guess. It can be a bad one. Yeah, she's got polio. All right. So what do we know about polio? Anything other than it was like a thing in the 50s and before? No, nothing. Okay. So polio is an enterovirus. So it's a virus that is passed through the digestive tract. So it is primarily passed through contaminated feces. So polio is spread through contact with those contaminated feces most of the time. So polio then was a virus that primarily affected kids because hands enough, right? And this really dreaded disease that could sometimes or oftentimes afflict children. And you'd have tens of thousands of cases in the US every year. Of those cases, there was one bad outbreak in New York in 6,000 kids died that year, but there was a particularly bad outbreak in New York. In 1950, 3,000 kids died of polio. And so it's one of those things where, polio is this really fearsome disease because it primarily afflicted kids, not, middle-aged people, not the elderly. So again, it's spread through the digestive tract. What polio does to cause paralysis and oftentimes to cause death is basically, so it moves into your small intestine. From your small intestine, it moves into your bloodstream. And then once it's in your bloodstream, it can go anywhere. How that pertains to what we're talking about now is that polio has a fairly unique ability to transport itself up or down a neuron, primarily up a neuron. So axonal transport is moving something up or down a neuron. If we're talking about anterograde axonal transport, we're moving something up the neuron. So we're moving it from the terminals. And so poliovirus has the ability to engage in anterograde axonal transport. It can move itself to the body of a motor neuron, where the virus replicates in the cell body of the motor neuron. It hijacks the machinery, like coronavirus. Hijacks the machinery, kills that motor neuron. Retrograde, as a temporary aside, retrograde axonal transport is moving down the axon. So when we need to make neurotransmitters, things like acetylcholine, things like glutamate, make those in the body of the cell, and then we're going to transport them down the axon out to the terminals. So that's a retrograde transport. Actually, I flipped those two. My bad in thinking about that. So if I screwed that up. So retrograde, flip those two. Retrograde's going back to the body, anterograde's away from the body. Sorry. So fix those notes. Because retro, after having talked about that for a minute, anything retro, so think about if you go to a retro party, an 80s party, right? It's back in time. So anything retro is going backwards. So at any rate, my mistake notwithstanding, once the virus replicates then in the body of the cell, it can kill that motor neuron. Well, if you kill that motor neuron, then all the muscle cells that it is connected to are going to, at the very least, atrophy, and many of them will die. Well, if motor neurons in your spinal or in the lower body are affected, then you're going to get weakness in the lower body. You're going to get possibly paralysis. So that was one of the potential of getting poliovirus. Now, I should say that poliovirus, in the vast majority of people, about 75%, is asymptomatic, doesn't produce any symptoms. About 25% of people that produce symptoms, or more like 24%, produce symptoms. But for the most part, those symptoms were like the flu. Body aches, fever, that kind of stuff. So some of this is probably sounding familiar. It's really interesting I made this slide like 3 years ago, and it's really interesting giving it in the middle of COVID, because you're seeing there's a lot of similarities, right? Obviously, they're both viruses. So only about a quarter of people actually had symptoms, and of those quarter, about 1% of them had paralysis. And of those people who were paralyzed, the ones who died, the paralysis had to be fairly high in the spinal cord. So if you get of the C3 level, it's called an iron lung. And so what an iron lung does is it inflates with air, and when it inflates, it compresses your chest, and so causes you to breathe. It's mechanical ventilation before we have the ventilators that we have now. So it's an external mechanical ventilation as opposed to the internal one through the trachea that we. So the individuals who died, it was because of that. So as an aside, one of the interesting things from my standpoint about polio is that it actually led to some pretty important discoveries with respect to rehab. So the thought after polio, after kids had been paralyzed, was, well, because the muscle is already damaged, you don't want to stress it too much. And so the guy who is doing the knee test, this guy here, his name was Thomas DeLorme. He's a physician, originally from Alabama, but most of his practice was in Chicago. And so what he said was, well, okay, I understand that the muscles are weakened and damaged, but what happens if we actually apply some stress? What happens if we actually make these patients lift relatively heavy weights? So challenging for them. And he found that the results are actually pretty good. Patients actually walked better after that higher intensity program, because what happens is you've got those weakened, atrophied, or disappeared muscle cells within that damaged muscle. The rest of the cells around it, if you strength train the muscle, will grow, and basically they can take up some of the slack. And so that was actually a pretty big innovation in polio treatment in the 1940s, was to have Jonas Salk was came out in the late 1950s, and so as a result of vaccination campaigns, polio is no longer naturally spread in the U.S. It is in some other parts of the world. I think Afghanistan and Pakistan it still is, but not here. So again, having made this slide 3 years ago, this was usually my advocacy for vaccines slide, which I would still advocate. I got my flu shot this year. As a historian, I've had students in this class who want to go into chiropractic and various different kinds of alternative medicine who tend to be very anti-vaccine. But as somebody who researches and writes primarily history, I think that we sort of have this luxury of forgetting how bad some of these diseases were, whether it's smallpox or diphtheria or polio or whatever, because we haven't seen them. And so I think that then leads people to be like, oh, vaccines are causing problems. Not compared to what smallpox does, or not compared to what polio does. So anyway, get your vaccines, kids. Yeah.
Was polio around like in the 16, 17, 1800s?
I would assume, but I don't actually know. I'm mostly just familiar with its impact in the U.S. I don't know much beyond the end of the 19th century on polio, but I would assume.
Yeah, the sewer system was pretty for sure.
Yeah.
It got passed around a lot more.
Yeah. One of the interesting parallels to polio, too, is with all the lockdowns and stuff now, is that in the 1940s and before, they know how it spread. And so it just happened to really have big outbreaks in the summers. And so everybody kind of freaked out at the end of the summer every year, and they closed down pools, and in the movie theater, and they made people sit 3 seats apart, and a number of other different things of just stay away from each other because we don't know how this thing spreads. And so there were some interesting similarities with how it was treated. All right, so some of this stuff we've already talked about. So the key thing I want you to remember on this slide, electrical signals, which I'm going to refer to both as and action potentials. But what I mean by that is that a neuron is sending an electrical signal. Remember, those only go one way. And so, again, we got 2 sets of neurons. You got sensory neurons, which are known as afferent neurons. They send sensory information. Neurons, efferent neurons, and interneurons sit between the sensory and the motor neuron. So interneurons are important for things like reflexes. So if you've ever gone to the doctor and had them do the patellar tendon reflex, where they tap on your patellar tendon and your leg straightens, you get sensory information coming up the cord saying that your quads are being stretched. That synapses with an interneuron, which then sends part of that signal goes up your brain, up to your brain, and then the other part of that signal connects to the neuron, which then causes the muscle contraction. So interneurons are this sort of intermediary between afferent and efferent neurons, and they can relay the signal to multiple other neurons. All right, so let's talk about sending electrical signals. So I mentioned this last time. A neuron at rest has what's referred to as a resting membrane potential, meaning, and so a neuron at rest, the inside of that cell, or particularly the inside of the cell membrane, is negative relative to the outside of the cell. So the intracellular fluid, or the intracellular aspect of the membrane, is negative. Extracellular outside is positive. All right, so some basic terminology on there. Voltage. So voltage is a measure of potential energy. So remember, back to your science classes you've had before. Potential energy is energy based on position. So you probably have seen pictures of like a ball at the top of the hill and talked about how much potential energy the ball has. Similar concept here with electricity. So it is, again, based on position. In the case of a neuron, you have lots of positive ions. So in terms of positively charged particles, primarily sodium outside of the cell, and only a few positively charged ions, primarily potassium, inside of the cell. And in concentration, lots of positive outside, not very much positive inside. You have a charge, which is voltage, a difference in potential energy. And so the resting potential, the resting charge of the cell, and one of the things that was super confusing for me the first time I had to learn all this stuff was, so we're talking about sodium, that's positive. Talking about potassium, that's positive. Those are the two big players here. How is the inside of the cell negative if both of the primary two things we're talking about are positive? And again, the answer is so much more sodium outside, so much more positive outside than there is positive inside. The inside is negative relative to the outside. So it's not absolute negative, negative relative. Current is the actual flow of electrons. So it's the flow of electrical energy, if you will. So current is the flow of electrons. Resistance, as you would have guessed, is impedance of those electrons. So we see different amounts of resistance in tissues of the body, for example. So tissues that have a higher water content have lower resistance to flow. And we capitalize on that with certain measurements. So for example, in some of your classes or at the gym or handheld one, it's like a little rectangular machine and you kind of grip onto these two metal parts, put in your age, your weight, etc. Hold onto it for 10 seconds and then it tells you your body fat percentage. There's scales that have little foot things too. And so what that does is it calculates how long it takes for the electrical signal to go from one side to the other. The higher your fat mass, the longer it's going to take for the electrical signal to get from one side to the other, because fat mass or fat tissue has water content, has a higher impedance to electrical flow, and so it slows the signal down. The more muscle mass you have, you got higher water content, the electrical signal travels faster. And so that's the way those things work. So lower resistance, it assumes you have more muscle mass. Says that current, which is the actual, again, movement of the electrons, the electrical flow, current is equal to the voltage, the charge difference, over the resistance. So Ohm's law says that current is equal to voltage over resistance. So we can make the current flow faster if we increase the difference in charge inside to outside of the cell, or if we somehow decrease the impedance. All right. So one of the things that you might have wondered is how is it there's a bunch of sodium outside, not very much potassium inside, but then sometimes they change position. And the answer to that is you have channel membrane of the cell, and think about a channel as basically a door or a window. Let's go with door. So leakage channels are actually doorways with no door. So leakage channels are always open. And so you do have some leakage channels along the axon and along the cell body of neurons that'll allow some potassium to leak out and allow some sodium to leak in. The cell membranes are less permeable to sodium, so not very much sodium leaks in through those channels, but some of it does. And another thing I haven't talked about yet is this concept of standpoint is they want to balance out. Sodium, if given the opportunity, wants to be equal in concentration outside of the cell and inside of the cell. But because the cell membrane won't put in, sodium is just kind of stuck outside until we open some doors. But once we open doors, i.e. channels, then that's going to allow sodium to move inside. So it's going to move with its concentration gradient from high concentration outside of the cell to the lower concentration inside of the cell, and goes the other way from inside to outside. So gated channels do have doors. Gated channels. First is chemically gated. And so what any of the first words mean on the gated channels is think about those as the key, the thing that opens the door. So in chemically gated channels, they open in a keyhole that when it so we already talked about gated channels with respect to muscle cells. So an alpha motor neuron at the motor end plate is going to release acetylcholine, which is a neurotransmitter. When the muscle cell receives that acetylcholine at those chemically gated channels, there's a receptor for acetylcholine on those chemically gated channels in a muscle cell. When it receives that acetylcholine, that's going to open the door. It's going to cause those channels to open. And so opening that door allows sodium to come in. As opposed to voltage-gated channels, open in response to a change in charge. So when the inside of the cell is very negative, so negative 55, so more, negative 60, negative 70. When the inside of the cell is very negative, voltage-gated channels are closed. But when the inside of the cell becomes more positive, voltage-gated channels open. And the basic pattern here, at least with respect to neurons, is that a neuron will receive a neurotransmitter, a chemical signal from another cell. That causes chemically gated channels to open. Whoops, I thought I had another picture on there. I guess I didn't. Okay. That's okay. So the basic process is a neuron at its dendrites will receive a chemical signal from another neuron. That causes your chemically gated channels to open. Sodium comes rushing inside. And then the area where sodium has just come in, because it's a positive ion, gets more positive. And so then that leads to the opening of voltage-gated channels. And then we get this wave of change in charge down the cell, which is called an action potential. So chemically gated channels typically lead to the opening of voltage-gated channels. So it's one then the other. Mechanically gated channels we'll talk about later, but the gist of it is mechanically gated channels open in response to deformation, a change in shape. So you have sensory organs in your skin, in your tendons, in your joint capsules, etc., that are mechanically gated. Whenever something presses you, back to your spinal cord and up to your brain. Mechanically gated channels, the key to their lock is physical deformation. You smash them or stretch them or whatever, but somehow you change the shape of that thing. All right, so I mentioned this. So resting membrane potential of a neuron is negative 70 millivolts. And the reason for that, again, lots of sodium outside, not very much potassium inside. So sodium is Na+, potassium is K+. And then the other things on there, ICF is intracellular fluid, so it's the water inside of the cell, or the fluid inside of the cell. Or outside, or fluid outside of the cell. All right. So, polarize something. Less negative. So if something is polarized, of electrical polarization, one side's positive, one side's negative. In a neuron, outside positive, inside negative. So if we depolarize it, we reduce that difference in charge. We remove it, right? So depolarization in the case of a neuron means that the inside becomes less negative. And another important concept is the threshold voltage. So the voltage for a neuron is 55 millivolts. The threshold voltage causes the opening of your voltage-gated channels. So once we hit that threshold voltage, the voltage-gated channels along the axon open up, and then that depolarization, that change in charge, becomes self-propagating, meaning that it's just this wave that continues along on its own. We don't need any further input. It'll do its thing. So threshold voltage, voltage-gated channels open. If you hyperpolarize something, what that means is that we make the inside of the cell more negative. So the way that we do that from a practical standpoint, some potassium to leak out of the cell, which if you lose positive ions makes the inside more negative. Or there's another that we haven't talked about yet, which is chloride, and it's Cl negative. So chloride is a negative ion, so we can allow some chloride to move inside of the cell. But either way, hyperpolarization, the thing that I'm most interested that you know, means that the inside of the cell becomes more negative. Why does that matter? That matters because the inside of the cell, again, at rest, it's negative 70. If we move the resting charge of the cell, if we allow some potassium to leak out, chloride to leak in, if we change the resting charge to negative 80, well, then we're that much farther from that threshold voltage. So it makes it harder for that neuron to send its electrical signal down the axon. So hyperpolarization inhibits the neuron or keeps it from firing. All right, so an action potential. Action potential is a wave of change in charge. The inside of the cell goes from negative to positive, so it flips charge. And that goes from the dendrites through the cell body, down the axon, and out to the axon terminals. So it's a change in charge. It's how the cell, it is the cell conducting an electrical signal that allows it to communicate with the other cells that it interacts with, whether those are other neurons or muscle cells. So at rest, again, lots of sodium outside, potassium inside. You have both sodium and potassium channels that are voltage gated. So your sodium channels have both activation gates and inactivation gates. At rest, the activation gates are closed, the inactivation gates are open. So what you're looking at with that is, so here's at rest up top, here's all the sodium out here. Here is your activation gate closed, the inactivation gate's down here. It's kind of this little swinging gate. So once the cell, again, here's the basic process. The cell the neurotransmitter would be glutamate. The cell receives glutamate. That opens chemically gated channels, chemically gated sodium channels, specifically. So then sodium comes rushing inside in that area of the dendrite. If enough sodium comes inside, then that's going to cause a change in charge of that area of the cell. So it moves from negative 70 to negative 55. Once that area of the dendrite hits negative 55, now we open the voltage-gated channels, depolarization. So we open the voltage-gated channels. Sodium comes rushing in, and you get that wave of change in charge. Then what the cell does is it goes from, again, negative 70 to negative 55. Then it goes up to actually positive 30 as all of the sodium comes rushing inside. And in order for the cell to send another signal, it has to go back to being negative again. And so how we do that initially, we're trying to repolarize, we're trying to reset that charge. How we do that initially is we open up some potassium channels. And so we're going to let a bunch of potassium leak out of the cell to return back to that original negative charge. So in doing that, we have to let too much potassium leak out, and so then the cell becomes too negative, so it drops down to negative 80 rather than negative 70 on the inside of it, and so the cell becomes hyperpolarized. And so for a less than millisecond there, it takes in another electrical signal. So it is temporarily inhibited. So there's only a certain number of times per second that a neuron can fire, and that's because there's only a certain rate at which these channels can operate, which makes sense. So then what we got to do, though, is we're going to have to pump potassium and pump sodium back out. So even though we've restored the original charge, there's still a flux or change in position of the ions. We have too much potassium outside and too much sodium inside. So we're going to use energy, we're going to use ATP to actually pump those ions either direction. We'll kick potassium back in, pump sodium back out until we restore the original ion concentrations, and then we're ready to go again. Oh, there it is. Nice. All right. Okay. So how fast that signal, the first is the diameter of the axon. So the larger the axon, so think about it as a 4-lane state highway. 4 lanes, traffic, you can move faster, right? So larger axons conduct the signals more quickly. The other thing, and we'll talk about that in more detail when we get to the peripheral nervous system, why that matters. And then the other thing on there, degree of myelination. So again, a myelinated axon transmits the electrical signal more quickly. And that's what's referred to. What it looks like is basically, so here's your little Schwann cells. Here's one, here's another one. So you only have those channels that I was talking about, those voltage gated channels at the gaps between. And so effectively, the electrical signal jumps from this gap to this gap to this gap, which is why the signal travels faster, as opposed to this sort of waterfall or cascade effect in an unmyelinated axon. It travels much more slowly. Tour time. All right. Don't worry about the stuff on here. There's 2 terminology things on here. The synaptic neuron is the one sending the signal, so it's the one that's going to be releasing the neurotransmitter. The postsynaptic neuron is the one receiving the neurotransmitter, receiving a signal, because that might be in some of the questions in terms of understanding the question. So presynaptic neuron is sending a signal, postsynaptic neuron is receiving a signal. The rest of the stuff doesn't matter. And it also terminology to back up one connection between neurons. And then you could get or I guess at the motor end plate. So don't worry about that. All right, so this is kind of the last set of, there's 2 sets of concepts left. So we can make it harder or easier for a neuron to fire. Or when I say fire, I'm referring to sending an action potential. So we can make it easier for a neuron to generate an action potential, or we can make it harder. If we make it easier for a neuron to generate an action potential, that's called facilitate. If you facilitate a neuron, you make it easier for it to send an action potential. If you inhibit a neuron, you make it harder. We have excitatory postsynaptic potentials, or EPSPs. So again, postsynaptic is a neuron that's receiving a signal. Is when a neuron receives a signal that causes it to become more positive on the inside. So what you're seeing here in the little graphic is over here. This is the neuron at rest, so negative 70 millivolts. And then it's going to receive an excitatory neurotransmitter, so glutamate in the central nervous system. We'll receive glutamate. That'll allow the opening of some chemically gated channels. And so then the inside of the cell becomes more positive. But it may not quite hit the threshold voltage. In this case, it didn't. And so the voltage gated channels don't open. But for this brief period of time, that neuron facilitated. If we get another signal, strong signal, so where would we see that? We would see that, think about if you're a sprinter getting ready to run 100-meter dash. You have to be able to react really fast to that starting gun, right? And so you know you're about to have to sprint, and so you are going to facilitate all of those motor neurons of glute max, hamstrings, gastroc, etc. of the hip extensors, plantar flexors. So we facilitate when we know we're going to have muscle contraction, for example. We'll facilitate the alpha motor neurons that are going to be responsible for the muscles that we need. Inhibition, on the other hand, is when we make the inside more negative. Synaptic potential, ESP, is where we make the inside of the cell more negative. We make it harder for that axon neuron to generate an action potential. So sticking with motor neurons, if we don't want that muscle to contract, we can inhibit the motor neuron responsible for it, or the motor neuron pool responsible for that muscle. So for example, since we were talking about vaccines earlier, so most vaccines are administered via a shot, right? And so if you're getting a shot in your delta, for example, you don't want to flinch. Much more intense stimulus in order to cause an action potential to be generated. So we them when we don't want them to contract. So you make them more negative. And so again, the way that that's done, we allow some potassium to leak out or chloride to leak in. All right. So the way that neurons can generate action potentials, there's a couple different ways. So summation, so if you sum something, you add it up, right? So if we either add up excitatory signals really quickly, that's called temporal summation. So temporal summation means I get multiple signals really close together in a short period of time. As opposed to spatial summation is where I get multiple signals from different neurons. And I'll show you what that looks like in a second. And so what you've got here on the graphic, so here's our little neuron, here's its dendrites, and then this is a presynaptic neuron. So again, the one sending the signal. And so it's going to send an excitatory signal. It's going to release glutamate. Our postsynaptic neuron is going to receive that glutamate, open up some chemically gated channels, and so its resting charge, there we go, is going to jump from -70 to, let's say, -56. So not quite high enough to get to the threshold voltage, so we don't open the voltage gated channels. And in that synapse, so in the space neuron and the postsynaptic neuron, you have enzymes that are going to degrade that neurotransmitter. So we're going to, as soon as that glutamate's released, we're going to start degrading it in the synapse, and we're going to degrade it at the chemically gated channels. And so as we degrade that glutamate, then we start to close those chemically gated channels. We're going to pump the sodium back out, and we return back to our original resting potential. Then we get another signal. So that causes the same thing. But we'd already returned back to potential. That wasn't quite enough to cause the opening of the voltage gated channels. Again, we didn't hit that threshold voltage. As opposed to, if we did it really fast, so boom, boom, then open up some of the chemically gated channels, we get another signal coming down the presynaptic neuron, release more glutamate, it opens more chemically gated channels, inside the cell becomes more positive, and we reach that threshold voltage. And so then once we reach that threshold voltage, boom, we'll open up those we'll open up the voltage gated channels. You get this big jump in positive charge of the cell and this wave of depolarization, which is an action potential. So temporal summation is when we send multiple signals in rapid succession that allow us to reach the threshold. Another important thing to understand about the way that the nervous system works is the intensity of a stimulus. The way that we code that is based on the frequency of action potentials. So when we want a stronger stimulus, or one of the ways, thinking back to the muscle chapter, that we can cause muscle contraction is, remember the rate coding, it means that the alpha motor neuron is going to depolarize more times per second, so with greater frequency. Low intensity contraction, alpha motor neuron depolarizes 30 times per second. High intensity contraction, 80 times per second. So the greater frequency of depolarization is a greater signal. And so that's kind of what's happened here with our temporal summation, is we got one signal, another signal, so two really quickly, and so greater intensity causes depolarization of the postsynaptic neuron. As opposed to spatial summation, so in the case of spatial summation, so we get input from this excitatory neuron, input from this excitatory neuron, and so since this one released glutamate and caused the opening of some chemically gated channels, this one also caused the opening of some chemically gated channels. So between the two, getting inputs from two places resulted in reaching that threshold voltage, and so then same process here. So temporal summation is time, two impulses or two excitatory stimuli in succession. Spatial summation is two different regions or different areas, but the results are the same. All right. I want to ask you about either of those two things. That's fine. All right. So know about inhibitory and excitatory postsynaptic potentials. And yeah, so that's the end of the fundamentals. And so next week, we're going to cover the brain in 2 days. So the first day, we're going to do the cerebral cortices or cerebral hemispheres. And then the other day, we're going to do like the thalamus, the hypothalamus, the cerebellum, etc. So yeah, so we'll see you next week.